COVID-19 disparities amongst racial groups, an ethical analysis. As a result of the human impact and structural causes of race-based health inequities amidst the COVID-19 pandemic and beyond, we suggest that employers be required to provide protective equipment and vaccinations to all workers for free, and, on the policy level, medical allocation processes be revised to consider non-medical factors in order to close racial health and mortality gaps. In our human impact analysis, we found that African Americans, Hispanics, and Latinx people contract COVID-19 at disproportionate rates, are hospitalized with COVID more frequently, and have greater COVID mortality rates when compared to white people. We found no scientific evidence indicating that these COVID-19 disparities are a result of any biological differences among the races. Rather, we examine the structural relationships and institutions that perpetuate such health inequities, finding that these racial and ethnic groups had overall worse health prior to the pandemic as a result of poor social determinants of health. Social determinants of health are environmental conditions that widely impact an individual's health, ability to function, and quality of life. One's environmental conditions are largely beyond their control, especially in cases where an individual's agency is constrained. Agency is often limited through social interactions and political processes which heavily affect a person's lived experience. Particularly relevant examples of these systems include poverty, racism, and a lack of access to care. In the absence of a national pandemic, these factors are still a grave concern, and race-based health inequities are structural injustices that raise major moral and ethical problems.
Iris Marion Young defines an instance of structural injustice as a negative consequence that results from a structural process in which a significant number of people participate in. Structural injustices are morally wrong. They result from oppressive political and social processes that disadvantage vulnerable individuals through no fault of their own. As Doctor of Philosophy Cynthia Jones puts it, it would be a strange leap to suppose that the members of a particular ethnic group are responsible for their lower health outcomes, or that the poor are responsible for their lack of access to adequate medical care. Contractualists view an act as morally wrong if any individual impacted by it can reject the principles on which the act is being justified. Utilitarians tend not to consider the moral basis of the act, but focus on the maximization of utility, generally accepting acts insofar as they are likely to bring about the greatest amount of happiness for the greatest number of people. Thus, a utilitarian may sometimes be inclined to ignore the disproportionately bad health outcomes of minorities if they are outnumbered by a large enough majority. Viewing these health inequities from a contractualist standpoint places an emphasis on the voices of those who are being harmed by these structural injustices and forces us to consider how more equitable medical resource allocation processes can decrease the severe outcomes of illnesses in African American, Hispanic, and Latinx populations beyond the COVID-19 pandemic. Regarding structural injustice and human rights, Elizabeth Ashford, a moral philosopher, raises questions surrounding the duties of individuals to combat these disadvantages and harms. She believes that humans have a positive duty to assist those who are underprivileged, meaning we are obligated to protect the interests of those who lack necessities insofar as their personal cost associated with doing so is reasonable. While immediate relief to these communities is not sufficient, it is necessary in order to alleviate suffering in the meantime. We believe that employers should be required to provide free proper protective equipment, weekly COVID tests, and offer vaccination clinics to their employees to accommodate for potential transportation, time, or expense problems that may arise from needing to travel elsewhere to receive vaccinations. Financing these services through companies saves individuals from personal expenses they may be unable to incur. The short-term financial burden placed on the company is reasonable when the number of potential lives this implementation could save is considered. In addition to this relief effort, in order to see real social and structural change beyond the borders of the pandemic, reform on the policy level is needed. Currently, the American Medical Association follows a scarce resource allocation policy that does not consider non-medical characteristics. However, the criterion says that the likelihood and anticipated duration of benefit should be considered. Alan Elbaum, a senior research assistant at UC San Francisco, criticizes the existing allocation process and raises an imperative question. What are the ethical implications of racial health disparities when it comes to end-of-life care? Is there such a thing as a good or dignified death when African Americans and other non-white patients are dying not merely of COVID-19, but of structural racism? Utilitarian rationing policies that perpetuate eugenic outcomes are still widespread. These allocation methods consider race to be morally irrelevant, which is incredibly dangerous. Blacks, Hispanics, and Latinx individuals have overall worse health when compared to whites and are thus more likely to present with severe, life-threatening symptoms more frequently, often as a result of pre-existing conditions that are reinforced by poor social determinants of health. In accordance with the utilitarian allocation policies, a hospital would extend curative care to a white patient over a same-aged African American patient who was admitted with more severe symptoms. This colorblind approach perpetuates the race mortality gap and disservices non-white individuals who are facing disproportionate injury, illness, and death because of exposure to racism.
A deviation from the traditional allocation process to a more holistic approach naturally raises questions. At the beginning of the pandemic, the New England Journal of Medicine outlined their recommendations for distributing COVID-19 resources to patients. In the statement of ethical values, physicians agreed that consensus exists that an individual person's wealth should not determine who lives or dies. While this appears to be a positive criterion, doctors are failing to account for the fact that an individual's socioeconomic status largely affects their overall health. Environmental pressures and prejudices increase the likelihood of developing underlying conditions and severe illnesses, which oftentimes lowers their future quality of life and ability to survive health setbacks, a factor that is considered when determining allocation. Due to the interconnectedness of the social determinants of health, it seems unreasonable to try and separate them from such pivotal decision-making processes. Further, we do not propose that these factors can be considered when two individuals who are age-matched are presenting similar prognosis. But when a patient presenting with more severe symptoms is at risk of being sacrificed in order to dedicate time and equipment to a patient who is already more likely to survive, we believe they should be. COVID-19